Hi, everyone, and thank you so much for joining. My name is Sasona Puyeye, and I am the Communications Assistant at the IBIS Johannesburg office. And as you know, today is International Women's Day, which is a globally recognized occasion to celebrate the achievements and contributions of women worldwide. This year, the UN has declared the theme to be Invest in Women, Accelerate Progress. And the theme for our webinar today is Investing in Women, Bridging the Gap through the Investment in Sexual and Reproductive Health, which aims to foster dialogue and provide insights into the pivotal role of investing in women to drive societal change and improved access to the sexual and reproductive health services. Our speakers for today, we have Nga Morombedzi, who is the Southern Africa Regional Advocacy, Policy and Marketing Manager at the AIDS Healthcare Foundation. Her career commitment is to engage and contribute to efforts to drive societal changes or to address societal challenges. She will be taking us through integrating mental health into sexual and reproductive initiatives. Our next speaker for the day is Dr. Jess Russell, who is an expert advisor on gender justice at the Center for Applied Legal Studies and on the board of the Sexual Reproductive Justice Coalition. She will be covering sexual and reproductive health and rights in South Africa and addressing those policy gaps. Our next speaker is Kelly Blanchard, who is the president at IBIS Reproductive Health, and her research has included clinical and social science studies on improving contraception and abortion technologies, including medication and surgical abortion, emergency contraception and oral contraceptives, expanding access to and quality of reproductive health services, and documenting the impact of policies on women's health around the world. Her topic will be the evolution of sexual and reproductive health in the United States and the implications for global strategies as a result of the Dobbs decision. Our last speaker for the day is Gugulethu Sihlali, who is a sexual and reproductive health rights advocate who sits as a youth advisory panel member at the UNFPA and has worked as an intern analyst at a consulting firm. Her topic is Empowering Futures, UNFPA's commitment to advancing women's sexual and reproductive health rights aged between 10 and 24. Thank you so much for coming, ladies, and for joining us. So before we delve into the presentations, I would just like to take a moment to highlight the interactive nature of our event. Your engagement is encouraged, and should you have any questions during the webinar, please use the Q&A section and simply pop your questions into the designated area, and we will address them during the dedicated Q&A segment at the end of the presentations. Without further delay, let's get into it and start with the first speaker, Nga Murambedzi, who will be taking us through integrating mental health into sexual and reproductive initiatives.
Thank you very much, Sesona. Good afternoon, ladies and gentlemen. Thank you for joining us for this very important discussion. By way of introduction, my name is Nga Murambedzi, as Sesona has already indicated. I am the Southern Africa Advocacy, Policy and Marketing Manager for AIDS Healthcare Foundation. AIDS Healthcare Foundation has operations in over 45 countries globally, and we are the leading provider of HIV healthcare. Our focus is looking at providing excellent services, but also advocacy for people living with HIV regardless of ability to pay. Now, this discussion is important for us because along with providing HIV services, we also work very closely with adolescents and young girls. And we are of the view that investing in young women and girls, not only across African countries, but globally, is one way in which we can combat the intersections with HIV and AIDS, amongst other psychosocial and social issues that plague women and girls. I will be looking down. My notes are on my phone, so it's not out of any way of being rude. Now, AIDS Healthcare Foundation fits into the reproductive health space, as I have indicated, because we work very closely with young women and girls. And of late, we have been advocating for a strong focus not only on SRHR for young people as an independent entity, but also looking at the intersections that contribute to the high levels of HIV amongst adolescents. One of the things that we have found is, although there are services that are targeting young women, young girls, young men of reproductive age, so when you're looking at the age between 10 and 24, there are also gaps, especially in sub-Saharan Africa. So we advocate for an exploration of micro and macro social contributing factors to access to reproductive health rights by young people. We are also mindful that women and girls are at a heightened risk to mental health and psychosocial issues as a result of societal and gendered norms. One of the challenges we have found, and I want to present Eswatini as a case study, is that for young women and girls, the cultural narrative impacts their health-seeking behavior. It impacts their access to contraceptives, for example, but it also impacts their gendered expressions. There is also an apparent need for combined interventions to jointly address the issues of adolescent SRHR, its intersection with HIV and AIDS, a focus on mental health, but also the importance of educating. All of these elements are currently being understudied. There's an imperative and a very apparent need that we need to strengthen investment towards understanding these intersections. But despite the evidence that these adverse social and community factors are rampant amongst adolescent populations, there's still very little that is being devoted by communities, by governments, by regional blocs towards addressing how do we combat that intersection for young people, that being SRHR, mental health. The second point I want to highlight is all the people that are gathered here today, we understand what SRH means. This is the right to make decisions concerning your own reproductive health. It's the freedom to do this in a way that doesn't expose you to discrimination and stigma. It is free of coercion and violence, but it also encompasses the right to privacy and confidentiality when you are seeking SRH services. Now, when we think of HIV treatment and how it mirrors how young people experience their quest for access to health services, one of the challenges we face is young people are hesitant to take up, especially HIV treatment, but also preventative measures such as condoms and contraceptive because of the negative attitudes of healthcare facility workers. And this greatly impacts their own mental well-being. One of the challenges also that they face is where we say SRH should be attained in a mutually respectful and equitable way that is devoid of gender relations. That's not always the case. I go back to the point of the cultural norms. There are perceptions on what is culturally acceptable for young women and young girls. The narrative of promiscuity always comes up when we engage with young girls and we ask, what are some of the challenges you face? And the response is generally when you go to a health facility, especially a health facility within the public health sector, there is a lot of discrimination and judgment that they face. That some young people leave the facility feeling disheartened, discouraged, but also in a way that leaves them prone to depression. One of the biggest mental health challenges of young women is depression. where they are seeking to express themselves fully through being able to exercise their sexual reproductive health rights, but there is no open avenue. So the recommendation in that regard would be, how can we capacitate the end user to be able to, in the face of discrimination, respond in a way that still exercises their own agency? Now, when we are looking at sub-Saharan Africa, I think we're all in agreement that our culture plays a significant role. Devoid of race, devoid of economic status, culture is one of the biggest drivers of how we show up in society. And so for the young people, whether they're living with HIV or not living with HIV, it becomes imperative that they understand why they should exercise their rights. Young girls, for example, that are not able to exercise their SRH, they are prone to unplanned, unwanted teenage pregnancies, meaning that from an education perspective, they are not going to be able to complete their education. From an economic perspective, they're not going to be able to participate in the economies around them. But also it means that they then fall into the poverty element that already drives the poor decision-making amongst young people. We also want to look at SRH and its intersection with mental health by addressing the policies that are in place. A desktop study indicates that there is very little exploration of the intersection of SRH and mental health amongst young people in sub-Saharan Africa. The findings of such studies will indicate that although there is an appreciation and an understanding that the two intersect, there's very little resources that are allocated towards exploring why young people have certain behaviors. Now, there's an interesting phenomenon that has arisen that has affected young people negatively. And I'm of the belief that it's not a new phenomenon, but because of the advent of social media and also the drive that is moving parents out of the homestead, out of the home setting, towards the diaspora or towards the metropolitans in search of economic opportunities, has left young people vulnerable. This is drug-induced sex parties. Now, within these drug-induced sex parties, which are happening a lot, Eswatini has indicated, Zimbabwe has indicated, South Africa has also indicated, there is very little access or seeking of protective measures. Now, there's very little condom usage, there's very little HIV testing, but what is apparent is a lot of the children or young people that are participating in these are looking for a sense of belonging. So when sometimes we say that mental health issues, people think depression. People think that somebody is bipolar. People think that you are facing a mental health challenge that is debilitating. But it's also the need for young people to find a sense of belonging to form their identity. So I highlight this because the health-seeking behavior of young people is also impacted by how they identify as individuals. And we need to, as decision makers, look at how can we strengthen such entities, such practices around young people so that they can make informed decisions. The other element I want to speak to is the social and community ecology, as well as the associated problems. Now, my background is in child protection and development studies, wherein I explored the lived realities of orphaned and vulnerable children in the face of abuse. One of the contributing factors to the mental health challenges that young people face today is the social and community ecology. Are they orphaned? Are they vulnerable to economic exploit? Are they vulnerable to sexual abuse? Are they homeless? And what are the cultural norms that are negative that are influencing their decision making? Now, we paint a bleak picture, but I am urging everyone to explore when you are providing SRH services. Are you considering the ecology in which the young person exists? There is many chemical responses to mental health challenges. And once we are able to balance that, we also influence the decision-making that a young person is then able to do. However, there are also barriers in which young people can take up things like medication. again, we lean on the cultural norms. There is a common practice amongst people of color wherein there is the belief that mental health challenges are racially profiled, which means when a young person, even when we're looking at the gendered expression, for example, LGBTQI communities, when they are seeking their reproductive health rights and they're having to navigate the negative expression where they come from, so from family, from religious entities, where they don't already recognize that child or that young person in the way they identify with themselves, you find that this results in the young person making ill-informed decisions. Not to stretch this discussion, and somebody once said to me, if you want to carry on for another 10 minutes, you then go to in conclusion. But the recommendation I would like to put forward is there is a need to address the common denominators of poor mental, psychosocial, and sexual reproductive health rights by implementing a multimodal and multi-pronged intervention for adolescents. Now, when we are saying multimodal or multi-pronged, mental health issues, sexual reproductive health issues, HIV issues are all public health crises that are affecting young people. They are not simply medical. They are not simply on a development agenda. They are not simply influenced by the economy when we look at the poverty, for example, but we all have to come together to look at what are the gaps in the current measures that are in place, but how does that intersect with our responses? How do our responses reflect the recognition that mental health challenges are parts and parcel influenced by the access to reproductive health services that young people have on hand? Then again, I want to just reiterate that in sub-Saharan Africa, mental health concerns are ranked as the least common category of problems targeted by SRHR vis-a-vis HIV interventions. So there is a deliberate or maybe an oversight in how we are curating interventions that are affecting and impacting the mental health of young people. Us from the HIV space are mindful of the different contributing factors to how people seek the health services for HIV interventions, but we are wanting to bring the SRH element as well. So that's something that I would recommend that we go forward and we engage. Overall, mental health interventions can be delivered in a way that accommodates young people, accommodates their lived realities, accommodates the end reality, the end goals of the implementers, such as us who are gathered in this room. And in order for us to do that, we can explore things like peer-to-peer training, peer-to-peer support, community engagement, family strengthening to respond to the mental health challenges of young people, but to also be appreciative of how to balance the sexual reproductive health seeking behavior amongst young people. I will stop there and just want to encourage that there is an intersection, I think, between not just HIV and SRH or mental health, but in a lot of the different micro and macro social interventions we are trying to do within the development agenda. Thank you.
Thank you so much for that, Nga. Just a reminder to everyone that if you do have any questions for Nga, you can just pop them into the Q&A section. But moving right along, we will hand over to our next speaker, Dr. Jess Russell, who is going to just be taking us through the sexual and reproductive health and justice landscape and the sexual health and rights in South Africa and addressing policy gaps. Over to you, Jess.
Hello, everyone, and happy Women's Day. It's really wonderful to be here with all of you. I'm very excited to share with you a little bit of my work and to talk about the overall policy landscape in South Africa and to explain a little bit about how that guides our current context and the justice issues that many women face. So first and foremost, whenever we're talking about sexual reproductive health rights in South Africa, we always like to explain that our laws and constitution focus on establishing the right to health in Section 27 of the 1996 Constitution. And this is really groundbreaking. In many other countries, they don't have this kind of protection. So it's a significant thing in terms of law and policy that South Africa has accomplished. And just to give a little bit more explanation and understanding of what sexual and reproductive health is, it encompasses all matters relating to our reproductive systems and our ability to expand the human family. The term sexual reproductive health implies that people are able to have a satisfying and safe sex life, the capability to reproduce, and the freedom, importantly, the freedom to decide if, when, and how often to do so. The rights aspect speaks to every individual having the right to make their own choices about their sexual and reproductive health, no matter their economic status, their social status, their political status. This is a kind of freedom that everyone should have. And so our laws and policies in South Africa underscore this. They include sexual and reproductive health rights. So, for example, the Choice on Termination of Pregnancy Act of 1996 provides a legal framework for the provision of abortion services up to 20 weeks gestation. This is a very important law that has also been amended and expanded since 1996. And, you know, it's unfortunately not a law that a lot of South Africans know about. Research tells us that people still are not aware that it is legal and safe to provide and access abortion services in South Africa, but that is the case. And abortion services, albeit limitedly, are provided in the public health care system across the country. I'll get back to a little bit more about that. First, I want to just share more of the laws that are important to guide sexual reproductive health rights. So we also have the Standing National Committee for Confidential Inquiries into Maternal Death that was promulgated in 1997. And this is very important because it sets out the law and policy framework, whereas if anyone dies during pregnancy or childbirth, this needs to be investigated, and there needs to be an understanding as to why and how this happened. This is important to prevent maternal deaths, but it's also important to enable people's missteps at this time of importance in one's life to be held accountable for any actions that lead to that death that could have been avoided. Then there's also the Sterilization Act, Act number 44 of 1998. And this is equally important because it provides the right to sterilization, meaning that if a male or a female chose not to have the ability to reproduce anymore, they didn't want that, they would be able to get a particular kind of surgery that would prevent that going forward. This right doesn't only allow for sterilization, but it also promotes autonomous decision-making and protects women and men through, for example, requiring voluntary, informed, and written consent before a sterilization occurs. This is very important, especially because in South Africa, we have a history of forced and coerced sterilization. Again, I'm going to get back to that as well later on. We already talked about the National Health Act of 2003 that spells out a little bit more of Section 27 of the Constitution, and it details the governance and oversight of healthcare services, including reproductive healthcare services, and what is included in terms of the public right to access to health. Then I understand that at this particular event, there are a lot of adolescents and young people here, and the Children's Act, number 38 of 2005, is very relevant for you because it empowers adolescents to be able to give consent to access reproductive health services and to test for HIV. Finally, I'm going to talk about the National Contraception Guidelines, which were last provided in 2019. And these provide for informed voluntary contraception and people's rights to exercise their reproductive choices. This guidelines really provide details, especially for nurses and doctors, to be able to understand what contraception is available in the National Family Planning Program that's provided by the state, in public health services throughout the country, but also it helps to understand how counseling should be done and the importance of explaining both the risks of each contraception as well as the benefits, so that anyone seeking to use contraception understands and is well informed to make a decision that is best for them. So part of the importance of having these laws is not only to provide access to people for the kinds of services that are needed, but also to enable justice and accountability. Like I said earlier, there are instances where preventable, where negative acts can be prevented. And these laws are supposed to be governing the system so that if anything preventable happens that is negative, that there can be accountability and justice. So, for example, one of the major issues that's happening in reproductive health and has been well documented in South Africa is an issue called obstetric violence. Obstetric violence is something that I define as physical or psychological violence that could also be unnecessary or coerced medical interventions carried out within reproductive health care services. So a recent study, a recent survey by one of our partners from the Sexual Reproductive Justice Coalition called Embrace Mothers Movement, got back these findings in terms of obstetric violence when they surveyed women who had been pregnant in South Africa. Predominantly, their responses were from the Western Cape and Gauteng, but they also had responses from 5 other provinces. So 23.8% of women said that they were ignored by healthcare providers when they were in active labor in the hospital giving birth. 21.9% said that they had received poor postnatal care. That's after they've given birth. 21.1% said that they had been shouted at by healthcare staff. Now, these are some of the main issues that happen. And to be shouted at when you are in a hospital, when you're in a clinic and you're there to get services, you're there to get education, to get information, maybe to get some tests, and to make some decisions, is a terrible situation. It's a demeaning situation. It's a humiliating situation. And it's also something that needs to be prevented and obviously is wrong. Other research has shown that this is something that pregnant women face, and anyone who is pregnant can face this problem, and it's been found to be widespread. So one of the things that also occurs is physical assault denying women treatment or services, which we heard in that study, the majority of women had said that they'd faced, but also unnecessary medical interventions. So for example, saying that someone needs a C-section in order to give birth safely when they actually don't, or when they don't want one. Another issue is forced or coerced medical interventions, including sterilization, which is something that has been a significant problem, particularly for HIV positive women. And also we have recorded there are issues of coercion when it comes to contraception, specifically in relation to implants and IUDs not being removed when it's been requested. I heard 1 or 2 reports of that from young adolescents in the Western Cape last year even, but also there's been an ongoing issue of people being coerced and forced into taking the 3-month injectable contraception, which is the generically known as Patagen, but its brand name is Depo-Provera. So these are issues where we see a collision between gender-based violence and reproductive health. And the state, in terms of its policy, has been doing something about it. In 2021, the South African maternal, perinatal, and neonatal health policy was released. And for the very first time, respectful maternity care was detailed and illustrated as a way to address some of these problems that women have been reporting in terms of abuses that they had faced in public health services while pregnant. So I'm just going to explain a little bit about this policy and what it says and what it's aiming to do, and to talk a little bit about what avenues people have to try to address these problems when they first come about. So the 2021 maternal health policy states that its main objective is to improve the delivery of a range of maternal, perinatal, and neonatal health services that are comprehensive, high quality, accessible, acceptable, respectful, effective, and safe, and to provide that equally to all individuals, communities in South Africa. It lists 5 objectives that it has at the policy level to be able to do this. The first is to strengthen leadership and accountability structures to provide quality, comprehensive care. The second objective is to strengthen the health system delivery platforms by addressing its building blocks in the continuum of care. The third objective is to promote access to respectful and non-judgmental maternal health services for pregnant individuals, women, newborns, and communities. The fourth objective is to promote coordinated, meaningful, multi-sectoral community engagement to enhance positive pregnancy and outcomes. That speaks back to the National Health Act of 2003 and its governance mechanisms, which aim to create a transparent system that the community can be engaged in and actually have oversight in as well. And finally, Objective 5 says to develop a sustainable surveillance system for maternal neonatal morbidity and mortality, including research developments and quality improvement. So this then speaks back to the 1998 National Committee on Confidential Inquiries into Maternal Death. So now that in 2021, we have this policy that oversees the system that actually foregrounds respectful maternity care, what we see is that it's not just about this Objective 3 that foregrounds respectful maternity care, but rather that each of these policy objectives are interdependent and has a key role to play in preventing and confronting what they call in the public health arena disrespect and abuse, and in more feminist circles, what is called obstetric violence. However, there's still a long way to go with these guidelines. One of the things that we've been discussing at the Sexual Reproductive Justice Coalition is that now that the guidelines are here and they're being released as we speak, and nurses and doctors are beginning to be, and administrators and managers are beginning to be trained on them. One of the things that we need to be doing in the reproductive rights space is to advocate that those trainings happen in person, not only online through the health system's knowledge hub, and they also be needing to be evaluated. There needs to be benchmark sets. We need to be taking accountability seriously when anyone complains of being coerced onto a contraception, issues of sterilization, or shouted at when they're pregnant. These are very important things because oftentimes what we found is that the complaints mechanisms to have accountability in the system is very fragmented, and women and families do not know where to go when they feel as though something has gone wrong and how they can actually address it there and then. What I always like to promote, because of this very fragmented and difficult system of accountability within the health system, is that we take advantage of the Health Ombudsman's office. For maybe 5 years now, we've had a health ombudsman, which is supposed to intervene and oversee all issues of human rights relating to health in the country. And they're supported by the Office of Health Standards and Compliance. They have a toll-free hotline that can be called between Monday to Friday from 8 to 5 and Saturdays from 8 to 1. So it's not 24 hours, but it is very available even on the weekends. And you can call that number. It's 080-911-6472. And that hotline allows you to talk to someone from the Office of Health Standards and Compliance, and you can tell them what your problem is, what your question is, what your grievance is, and they will make sure to follow up directly with the head of the hospital, the head of the clinic, to find out exactly what's wrong, to make sure there's documentation, so the MEC in whichever province it is, the head of the Department of Health in whichever province it is, has documentation that there's been a complaint. And unfortunately, it still seems to be a burden on the user, the patient, to follow up with the Health Ombudsman's office, again, by calling that same toll-free number, then to find out, okay, what has happened? Who do I speak to next? What can I do? But that is the first step towards bringing accountability, is that kind of documentation. And because this is a nationally mandated position that the Health Ombudsman is supposed to be overseeing, we find that there are good results. This call center, this hotline, is meant to respond to people and document that. And because it's embedded within the system, we find that there are good results. There's quick turnaround times. And that is very helpful, because when you're having a distressing situation, you need a quick response. And this is the place that I would suggest one would go to. I'm going to leave it there for now. I know this has already been a lot, giving you some of the overarching legal and policy framework, but I hope that that gives you a little bit of an insight into what you can expect when you're trying to access health, reproductive health services in South Africa, and also to give you a place to go to if you ever encounter an issue, or if anyone that you know does. Thank you so much.
Thank you so much for that, Jess.
You're welcome.
We are now moving into we're now moving on to our next speaker. But before that, just a reminder, you don't need to wait till the end of the session to ask your questions. Just pop them into the Q&A and we will definitely get to them at the end of the presentations. And now we're moving on to Kelly Blanchard, who will be covering the evolution of SRH in the United States. Thank you so much, Kelly.
Thank you so much. I do have some slides. Thank you, Sesona. It is a real pleasure to be here with all of you on this International Women's Day. I am going to spend just a few minutes talking a bit about sexual and reproductive health and rights in the United States and the transformation, some of the implications, both within the United States and around the world, from the Dobbs decision that overturned Roe versus Wade, which protected access to abortion rights in the United States. Next slide, please. So many of you may know the United States is a large country, but most importantly, it's made up of 50 separate states and a number of territories, which each have their own governance. And like similar to South Africa and other places, it's a federal structure where we both have a federal national government and federal courts. The Supreme Court is the highest court of the land. But each individual state also has a number of legislative and court and legal it has its own infrastructure and legislative approaches and politics and systems. So there's quite a wide range of different contexts within the United States. One context that is important, though, as we talk about health generally and about sexual and reproductive health rights and justice, is the fact that there is not universal access to healthcare in the United States. Our healthcare system is extremely fragmented. It is for-profit system largely. We do have a national system called Medicaid, which is a system that supports healthcare for people living with low incomes. But that system is a joint federal government and state government system. And so again, the implementation of that system can be different state by state by state. And importantly, as we begin to talk about specifically abortion access, and as one particular type of healthcare, there are federal restrictions that prevent the use of federal funding for abortion care. And so within that system, the very inadequate system that doesn't cover many people, but even for people within that system with low incomes, many of the programs that are available cannot be used for abortion care. So that's just the very quick summary of the healthcare system where we're starting from. And we know that this system is extremely ineffective, unjust, and does not support people's sexual and reproductive health and rights, let alone provide justice and access to healthcare. And if you can show the next slide, please. One very obvious example, when you look here, these are some of the wealthiest nations across the world. The US, of course, is one of the wealthiest nations in the world. Despite the fact that we spend more money per person than anyone else on healthcare, we have the highest maternal mortality rate across these OECD nations. And also importantly, within this extremely high maternal mortality rate, which shows that our healthcare system is failing people who are pregnant, the maternal mortality rate for Black women is 3 to 4 times that of white women in the United States, which also again is a result of the history of racism and injustice that continues in our healthcare system today and prevents people from accessing high quality care. So that's just one example. There are many others to see how the US healthcare system is failing our population, and specifically people of color and people with lower incomes. Next slide, please. Prior to 2022, many of you will know, access to abortion in the United States was protected based on the Supreme Court's Roe versus Wade decision from 1973. And what that decision had said was that our Constitution and a number of the provisions in the Constitution protected people's access to abortion care, with a number of caveats, but I'm not a lawyer, and we'll just speak about the broad legal protections for now. That Roe versus Wade absolutely did not provide access to abortion care for everyone. Like other health care, many people did not have access or could not afford care. However, it did set a floor, which meant that states could not ban abortion care, and that individuals had a right to access abortion care. But in 2022, as most of you know, the Supreme Court reviewed a case out of the state of Mississippi, Dobbs versus Jackson Women's Health Clinic, when this particular group of Supreme Court justices overturned Roe versus Wade and said that the Constitution does not, in their interpretation, protect people's right to access to abortion care. So, to be very clear, the ruling says that our Constitution does not protect it. There are, within US state constitutions and other parts of our legal structure, places where people have found other ways to interpret the laws and the various levels of legal protection in the United States to support access to abortion care. But essentially what the Dobbs decision did was remove that floor that had been there with the Roe versus Wade decision and opened up the possibility that individual states could pass laws, or in fact, revive old laws that limited access to abortion care. So what were the implications within the United States? So next slide, please. Very quickly after the decision, we saw a wave of abortion bans take effect. So the dark red states here are, as you can see, what are termed the most restrictive states, where essentially abortion access is not available at all. In some of these states, there had been very limited access before the Dobbs decision. There were a number of states, for example, that had only one clinic or very limited access to abortion care. But as once the Dobbs decision happened, many of these states had old laws on their books, often from the 1800s, that were interpreted to restrict access to abortion care, that were revived or interpreted as now in effect again once Roe's protections were removed. But we saw a wave across the United States of individual states banning abortion access. Now, interestingly, we also saw in a number of states, including Massachusetts, where I live, states take proactive measures to protect access to abortion care. So that looked, there were different ways that states did that across the United States. It included enshrining abortion in state constitutions. It included taking old laws off the books, old laws that had been around since before Roe versus Wade, but finally legislatures actually removed those laws formally. States put increased money into supporting people to access abortion care. We saw that happen at the state level, at the city level. And we also saw states interpret their own laws to allow for abortion further along in pregnancy, and to support people who needed to travel to their states, to expand access for people coming from outside of their states. So we did see in the wake of the Dobbs decision some proactive actions as well, at the same time where we saw some states completely ban and eliminate access to abortion care. Next slide, please. There have been a number of ways you can see how the Dobbs decision has impacted people's health in very negative ways. This picture on the right is a group of plaintiffs in the state of Texas. These are people who were pregnant and were suffering complications that could have been treated with access to abortion care. That care was denied, and they are now suing the state of Texas, asserting that even the supposed exceptions to protect someone's life are not effective, and that their rights were violated because of the restrictions on access to abortion care. As you see on the bottom right here, the result of the wave of bans across the country has also led to the fact that many people have to travel long distances. And of course, it's not only the time to travel, it's the cost of travel, the cost of childcare, the time people might have to take away from their jobs. The implications are really huge for people who live in states that are now banning access to abortion care. And this chart on the left side shows the dramatic drop in abortions provided in the states where abortion bans took effect, and really just highlights how the states in orange, for example, the brighter orange, people were traveling to those states, often traveling thousands and thousands of miles to access the care that they wanted. Next slide, please. And of course, there's not only the impact of the ruling within the United States and for people seeking care within the United States, but the US is the largest global funder of sexual and reproductive health services and products around the world. The US also has its policies impact not only funding dedicated to SRHR, but also funding that is meant to support development broadly, or HIV, or other in other areas where the US is providing development aid. So I want to lift up this report from our colleagues at FOS Feminista, where they collected information on how the Dobbs ruling had an impact outside of the United States. And you can see here, both in many countries, in Kenya, in Nigeria, in India, the Dobbs ruling has been referred to in efforts to roll back access to abortion care, or to limit or support restrictions on abortion in a wide range of places around the world. Next slide, please. And of course, there are those specific cases where the ruling might be referred to limit access to abortion care. But there also is the implication of how the Dobbs decision and the impact of who is in the White House in the United States impacts, again, what funding can be used for, and whether or not it can support sexual and reproductive health rights and justice around the world. The Helms Amendment in the United States restricts the use of US funding for abortion care. But I think it's important that the current administration, in the wake of the Dobbs decision, is attempting to expand the interpretation of the Helms Amendment to say that US funding can be used in cases where there has been sexual violence or someone's life is at risk and abortion care is legal and available. So we do see some progress in the interpretation and trying to broaden the understanding of the Helms Amendment. But of course, like all of you in South Africa, this is an election year for us too. And the interpretation of the Helms Amendment and the implementation of things like the global gag rule, sadly, as we all know, can change with a changing administration. So that will be something to keep an eye on as we approach our election in November. And also, the election will also have implications on the amount of funding that the US provides globally for sexual and reproductive health rights and justice. So this, the Dobbs ruling has had a dramatic impact on people within the United States and their ability to access the abortion care that they need and that they want, but also has impacts beyond the United States. And hopefully we will see repeal of the Helms Amendment. That is a goal of sexual and reproductive health rights and justice organizations and advocates in the United States who continue to fight for the repeal and also for increased funding to support SRHR around the world. And that is the end. Thank you very much.
Thank you so much, Kelly. Just another reminder again, if you do have any questions, we see them coming in, just pop them into the Q&A and Kelly will be able to answer some of those, our speakers rather will be able to answer some of those during the Q&A section. Now, moving on to our next speaker, discussing the UNFPA's commitment to advancing young women's sexual and reproductive health and rights aged 10 to 24, Gugulethu Sihlali, who is on the UNFPA Youth Advisory Panel, is coming up now.
Thank you so much, Sesona. Good afternoon to all the honorable human beings in the glory of their chosen identities. I am Gugulethu Sihlali, UNFPA Youth Advisory Panel member, and I'll just be speaking about commitment. But before we speak about commitment, we ought to speak about context. I think context remains a big part of the contribution to policy, the contribution to how far we've gotten within strides in progress in gender equality or towards gender equality. And perhaps I think maybe that's a good place to start. So from the topic, I'll nitpick certain parts that I think are important. So for instance, what do we mean when we speak about empowering futures? And so far, what have been the strides towards gender equality, especially in a South African context? And then we'll speak about SRHR in itself, and then we'll go into the commitment. But I think when we speak about empowering futures, it's a very important conversation that we ought to have, especially because when we speak about adolescents, we are speaking about the future. And so when we speak about empowering futures, I think we ought to speak about prioritization and how do we prioritize the people who will be in the future. And so when we do speak about empowering, I think it links perfectly to today's theme of investing and what investing actually looks like in an SRHR context. But what is SRHR? And I think my panelists have spoken well to it and alluded to it. And I think in essence, it's about the creation of personal agency for whoever needs to be practicing said right. Personal agency in order to be making the right decisions. Dr. Jess speaks about being informed enough in order to make the right decisions, so that people are making informed decisions, particularly adolescents who remain so vulnerable, who eloquently explained how these adolescents are particularly vulnerable, looking at the spatial climate and how their parents would have to leave for economic purposes, and that leaves them as very vulnerable. When we do look at adolescents in a South African context, it goes without saying to highlight the added responsibilities that exist for them because of the socioeconomic standing and just generally how things are. So the responsibility is on adolescents, whether they are heads of household or they stay in households with parents, but there is an added responsibility because of the contextual history that comes with apartheid and colonialism and how that has set a reality for these adolescents. And so I think today it has been such an informative session, and why are we making strides towards gender equality, and why do we need to continue? I think we've made gorgeous strides. We hear about policies from Dr. Jess. We hear about just the framing from Nga when she speaks about how certain policies and certain narratives frame a specific norm around these adolescents or young girls or young women. And so we've made beautiful strides in progress. However, there's still a lot to be made. We hear from Tanya now, who just, not Tanya, sorry, from Kelly now, who just spoke about the overturning of Roe versus Wade and how that could potentially have harms for all the world's policy on sexual and reproductive health rights. And perhaps that's what we speak about when we say we need to invest more, and what we speak about when we speak about commitment. The fact that the bodies and lives of women still remain so disposable that one court case can overturn legislature and laws that have existed for so long is perhaps the conversations we should be having. And perhaps this is also just a reflection on how systems and processes, despite many progresses, still remain very patriarchal in their nature and still center the voice of the man. And so let's speak about the commitment of the UNFPA. The UNFPA is an institution that focuses on sexual and reproductive health rights for specifically adolescents and young women. And their commitment is in different spaces and can be recognized and seen in a lot of ways. Firstly, UNFPA has a great commitment to policy action. And so the very great, eloquent policies that we may see in gender. The other day, we were sitting in a focus group where we were looking at a policy specifically for adolescents. And so there is great contribution to policy in how we make sure that we frame and center the adolescent and young woman, and we ensure that there's a better reality for them and better lives for them. And we also continue to make strides in progress towards gender equality. But I think also the most important one, and perhaps a conversation we should have in more depth, is UNFPA's commitment to including adolescents and youth in decision-making. The South African space currently, as progressed as it is, still simultaneously existing with its challenges, has made norm of not including the people that it needs to include in the decision-making. And when these people aren't in the right spaces to make the decisions, then the decisions aren't as comprehensive as they should be. And these decisions just exist as concepts for concepts and not for people. And perhaps that is the essence of setting policy. Are we making sure that we are not setting policies for people that don't exist in the actual societies? And when we are setting policies, who are we setting a policy for? I went for supervision the other day as I'm doing my master's, and my supervisor said to me, "Who is this adolescent girl that you speak about? Describe them." And if we're looking at the South African space, when we speak about an adolescent in a township or in a rural area, we will speak about a Black adolescent. And with all the diversities that exist and are included in the South African space, we can speak about the migrant, we can speak about the refugee adolescent, we can speak about the white adolescent. And so it does become important that we include these adolescents in these decision-making so that their voices is felt within these policies. When we're setting policies, when we're implementing, and when we're investing, who exactly are we implementing, setting policy and investing for? How do these people look like? And what is their stories? Because their stories are different and their stories matter. And so this is what makes it easy for us to get into situations where we have an issue of Roe versus Wade and the global gag rule that takes over our lives and changes the strides and progress that we've made. Because even in this progress that we've made, we still don't have the correct people sitting in these places. And even when we do set these policies, we don't have the people's voices in them. So when we do speak about adolescents, are we taking in the historical backgrounds that could have placed the set contexts for these adolescents that we view them in light of? Are we taking in the historical contexts that have made the realities of these adolescents? And are we taking in the realities of the adolescents now? And so those become important things. And UNFPA's commitment to including the adolescent and young woman in decision-making, which I, for one, am the inclusion as I sit as a youth advisory panel member, is one of the big commitments that we hope to see, especially in a political climate that is changing with elections coming up. We hope to see this happening more so that our voices are asserted even more and we continue to see our voices. And moreover, so that the policies and legislations are for people and not just concepts that we are writing about in textbooks, especially when we look at the different spheres of how knowledge production is created and who has the power to create this knowledge production. And lastly, investing in civil society. I think civil society has a very big presence in South Africa, and civil society's work is seen all round through. So civil society is your youth that are doing work on the ground, it's your soul cities, it's your gift of the givers, all these organizations who are going out of their way to make sure that change is happening and work in collaboration with government or for government. But the investment in civil society remains very important. And perhaps when we do speak and internalize today's theme about investment, we need to recognize what investment is. Investment is not just being able to give people money, but it also looks at equitably distributing power. Are these people able to sit in decision-making spaces? Are these people able to make a bigger impact than just the impact of 5 people? And sometimes equitably distributing power means making sure that we give these people money consistently and we invest in it. And so UNFPA's commitment continues and gives an opportunity for there to be strides in progress. But these strides in progress and these commitments are not without the reality of how the government plays a huge role in all of these things. And so perhaps maybe it is a discussion, a bigger discussion of, yes, there is commitment from civil society, there is commitment from these organizations that are as big as the UN and are international, but what is the commitment of the people that we hold in government or we put in government? And how do we continue to hold these people accountable? Because things like sexual and reproductive health rights remain very important and could mean life or death for the people, the adolescents, and the young people. And so perhaps today, when we think and internalize investment, we should really think about how it is also our responsibility in this investment that we hold the people that we should be holding to account, and that we make sure that these people that have the greatest amount of power are actually instilling their power as they should correctly, and if not, that we are holding them accountable. And with that being said, thank you so much, and I hope today was a great day for everyone, and happy International Women's Day.
Thank you so much for sharing, Gugu. And thank you to all our speakers really for sharing these insights. We are now moving into our Q&A session. So if anyone has any questions, those are going to be answered now, and you can feel free to ask them and we'll answer them right now. And we do have a couple of questions already. And the first questions come from Swazi Kabongo, who asks Dr. Jess, what happens if women want to report an abuse case but do not know any toll-free numbers? And her second question is, how do women who don't understand any of the national languages report abusive acts? I'm not sure if
Thank you so
Jess is
much
still
for
with
those
us.
questions.
Okay.
I basically there are many different procedures, like I said, for reporting abuses. And the main one is that you go to the, if you're already at the clinic or the hospital, or you go to the clinic at the hospital where this grievance took place, and then you ask to speak to the manager of the clinic, or the manager of the hospital, the manager of the department, and then you lodge a complaint. Most users of the public health system will know, they'll have seen complaints and compliment boxes. So these complaints go into those boxes, so it can also be a little bit anonymous. However, I recommend that you use this toll-free hotline, and I will also put it in one of the chats for people to be able to have. There's also a website for the Office of Health Standards and Compliance, and it has the toll-free number and everything there, because there's a better record of it, and it's not something that any manager can just discard or not pay attention to, not escalate to a higher level, because you're going to the actual oversight independent body, and this is their job. And they would not really be able to ignore a call because it's all recorded, etc. And they do everything over email, following up with the MEC and the Department of Health. So there are many other ways. You can also write to the MEC within your province as well, etc. I just always recommend the Office of Health Standards and Compliance, because I think that you get the best response in that way. In relation to the second question, I'm sorry, can someone just read that again? I'm trying to look at it here. Howie, I think it answers.
It's how do women who don't understand any of the national
yes.
languages report abusive acts?
Yes. So that's a very important question. And we do know that there's different kinds of discrimination that happen in South Africa relating to Afrophobia, or what's called xenophobia, but also within provinces. For example, I had one patient who was not pregnant, but was seeking sexual reproductive health services at Fruitiscure Hospital a number of years ago, and was a Zulu woman, and she was getting penalized because she wasn't speaking Xhosa properly. And this is discrimination. So this is a South African woman, right? Who's speaking one of the largest spoken languages in the country. So we do have reports from Somali women, Mozambican women who are not speaking one of the 17 national languages in South Africa. And there are laws that provide translation, but in reality that translation is less available. So one of the things that health services managers try to do, and often happens, is if the woman, the patient, has a trusted person who can both speak her language and English or whatever other language is spoken at the hospital, then she needs to be accompanied by a translator. You know, and unfortunately that really is the best that is being done at the moment. Are there any follow-ups in relation to that, or did I satisfy your questions? I did put this contact number in one of the chats. I don't know if someone else can just make sure that goes to all the participants. But I can't stress enough that we really need to utilize the health ombudsman. That's what they're there for. And I feel like we can do so much by utilizing their office. Right now, their indicators are not for their quarterly reports evaluating the hospital system is not focused on SRHR, and we need to push for those indicators to be in their quarterly reports. It will make a huge difference if we start utilizing their office. So that is really the best place, in my opinion. Thank you so much for the very important questions.
Yeah. Thank you so much, Jess. And then our next question comes from Prawe, to you, Kelly. And they ask, in light of France's recent announcement that abortion is now enshrined in their constitution, does this bode well for women's SRH rights worldwide and particularly in the US?
Thank you for bringing up that wonderful moment when France took that important step to enshrine access to abortion care in their constitution. It was really inspiring. So in reference to the US, sadly, our government appears completely unable to function at the moment. And then secondly, I think the politics at the moment mean we won't see something similar soon. But I think what that advance in France shows, you know, along with what we've seen in Latin America, the Green Wave and decriminalization of abortion across many countries in Latin America, we've also seen, you know, for example, in Benin, advances in access to abortion care. And we've seen globally, we've seen recognition of abortion as a key piece of human rights and health rights. At the same time, as we see across the globe rises in autocracy, in fascism, we see countries like in Hungary, like what we're seeing in the United States, like what we've seen, some very concerning prosecutions of people in the United Kingdom. And so it's holding both of these at once while we see tides of people fighting against rights of LGBTQIA+ folks. At the same time, when we see an increased acknowledgement and work on inclusion, I loved the way Guguletu said it about, I forget the phrase, but all of our beautiful identities that we bring with us. So both of these things are existing at the same time. And I think we need to both hold on to hope and watch those models where we're seeing successful advance and support of human rights and support of sexual and reproductive health rights and justice, while keeping our eyes very carefully on places, and this is where we are in the United States at the moment, where we need to really fight the trends towards rolling back our rights. And I will also just take the opportunity to say, even in places where abortion rights are restricted, we know that people continue to access abortion care. And we know and have been very proud at IBIS to conduct research on self-managed abortion and abortion with support from accompaniment providers and hotline providers. There are ways for people to access the abortion care they need that are safe and effective and can be supported. So people will continue to have abortion care. The goal must be to respect those rights and provide that care in a high quality, safe, and effective way for everyone. So we continue to march towards that goal.
Thank you so much for that rich answer, Kelly. And then we have two more anonymous questions. The first one is directed to all the speakers, and it asks, how can men get involved in the advocacy work of empowering and improving women's access to SRH?
I'll go first. I think it's just a matter of men first understanding, one, that nobody's exempt from the patriarchal system. So everyone is in a position to feel the consequences of it. And then I think also just to recognize their privilege. I think most times why it becomes difficult to be accepting of men in these spaces is because of their ignorance of their privilege and their non-acceptance, because their privilege can often come in these spaces and as an exertion of power, which could be problematic. Yes, you're trying to help, but you're not trying to help people who are devoid of personal agency, or who cannot think for themselves, or who cannot make decisions for themselves. And so when you do come into these spaces, you need to be very aware of those things. But also there's always space to come in, especially when you do hold the power that you hold in said society. There's always room for you to make space for people, and also for you to delegate your own power and uplift the others. But I think the game is to always be conscious of your privilege and your power, and then you're able to use it correctly.
Guy, you have your hand raised. Do you want to come in?
Thanks, Sesona. Thanks, Gugu. And thank you very much to I'm hoping it's a man who has asked this question. And one of the things we have to be cognizant of when we're speaking to societal issues is to ungender them. Yes, the negative experiences that women face in SRH are largely an embodiment or embodied by us as women, but the responses to them don't have to be gendered. The advocacy space has to be non-gendered. We have space for men, we have space for women, we have space for somebody who is directly impacted versus somebody who's got a sister, a mother, a grandmother. Somewhere, somehow, we are surrounded by women. And I think, as Gugu was saying, that if men can recognize their privilege, and I'm even hesitant to say that, because that means that they can then opt out. If I refuse to recognize my privilege, well, then perhaps I don't have to participate. But I think if we start to encourage or present these discussions in an ungendered way, it's like menstrual hygiene, for example. Menstrual hygiene is not only a female issue, it affects even the men that are surrounded by women. So I would say in response to that is to approach such discussions, such advocacy and policy spaces in a very ungendered way. Don't go in saying, okay, well, as a man, where do I fit in? Because also as women, we have to be very honest. There is 5 of us, 6 of us women on this call who are speaking to this issue. Already, that's just showing you just how many women are within this advocacy space. There is no gender balance even in this discussion. So us as women, it may be just, it could be like a response to how we have experienced it, where we're saying, okay, this is a space where we negatively experience. We want to change the narrative for ourselves. But societal issues, the only way we can combat them is to make men understand that you are one day going to be a father to a girl child. If you want to make a difference for your girl child or for your sister or for your mother, you have to be actively and deliberately involved in such discussions.
Thank you so much for that, Nga. Jess, Kelly, any words?
I think the points have been beautifully made, that, this is really about our families, our communities, the people who we love, the people all around us whose health and well-being we care about. And we can't avoid, again, as was said, the patriarchy impacts all of us, but the patriarchy is very visible in who sits in political power in many of our countries. And so there's no question that using all of our levers and all of the people who believe in our rights, our human rights, of the human rights and freedoms that each and every one of us need and deserve, that we need to take steps to ensure that everyone who can be is standing with us, whether it's as a voter, as an individual, or as a policymaker, as a healthcare provider, as an advocate, as a researcher. There are all kinds of different levels and ways in which people can participate, and people of every gender, of the full range of genders, have experience of sexual and reproductive health rights challenges that unite us together and mean that we all standing together will be more powerful and more effective in ensuring we can advance access to the healthcare that we need and the rights that we deserve.
Thank you for that, Kelly. And Jess, do you have anything you'd like to share?
I just want to say thank you. This has been a very informative panel also for me. Getting to hear just the diversity of voices, I think is really important. And I just cannot stress enough that people often do not complain. They don't complain enough at the health system level about getting the information that they need. I did a study not so long ago looking at coercion relating to contraception. And what we found was that people are not getting counseled. The nurses themselves say that they're not telling women about the risks of the contraception that they're advising them to take. They're only telling them about the benefits. And it's when we ask for the information that we get it. If we're not showing up and asking for the information that we want, asking for the redress that we want, we won't get it. And so many times our sort of feeling of an ability to ask and to be proactive in the healthcare setting relates to the hierarchy of power. The doctor and the nurse are always going to be more powerful than any of us who are not a doctor or nurse. There are class and racial issues to the way that we feel confident enough to ask questions that we really might be concerned about, or to speak up when something has been done wrong to us. And I just want to really stress how important it is for you, for your families, to really feel confident and comfortable to say something when you need to. And we do find, especially in the counseling settings, that nurses can respond. They do have answers, or they are sometimes willing to go and find them for you. But if nobody asks, then it's a lost opportunity. We know that the context is very difficult, and that people also fear being punished for complaining. Again, this is part of the reason that I'm suggesting the hotline, which takes the complaint outside of the individual clinic and facility. And those fears are real, and health workers themselves even have that. However, we know that if we don't stick up for our rights, they start to disintegrate even more. And so I just urge everyone to really be advocates for themselves and their families as well. Thank you so much.
Thank you so much for that, Jess. We have one last question, and that is directed to Nga. And the question is, how do we work on an individual level to address/redress the cultural narratives that impact health-seeking behaviors?
Thank you for that. I would bring it back I think everyone has touched on it at a certain level. And Kelly specified it in that, well, I think, yes, it was Kelly, possibly Jess. The agency you possess as an individual has so much power to help you redress a lot of situations. And we exist in a context wherein, even culturally, speaking up is not promoted at the degree that it should be. Because the people we have to speak up against, such as decision makers, are elders, adults, wherein, as you are socialized, you do not speak up against adults. So already we're existing on a back foot. And it's not a people of culture thing. It's not an African thing. It even goes back to religious, economic. You don't speak back to your boss. You don't speak back to the pastor. So many things within our social context. However, when we now begin advocacy efforts, we begin by saying, as an individual, deliberately capacitate yourself with the understanding that you cannot change the bigger picture as one entity. You have to, if I understand as Nga, say, for example, the issues that affect young women within my community, I am able to then gather the women around me because I understand as an individual. And the best thing you can do if you're going to be an advocate is to bring facts rather than just emotion. A lot of the efforts that we make, we lose them because then you become like a vigilante. You are just emotionally speaking to different situations. But if you bring factual evidence to show that, say, for example, the health-seeking behavior of young people is negatively impacted by XYZ, the attitude of healthcare workers needs to be addressed by, say, for example, as already was presented, capacity building, bringing them together, training them, breaking down those red tapes that young people have to experience, then that's the best that you can do. So in answer to, as an individual, what can you do? You are starting to break down even your own understanding. If you are by yourself, are you able, if, say, for example, today they say, well, you can't go to the place you want to go, say church, say wherever it is, are you able to advocate for yourself and say, yes, I want to go because XYZ? When you have mastered that, you can then widen the circle of influence wherein you are able to exercise your agency. It's not impossible, but you have to then on the other side be prepared for the drawback. There's a lot of negativity that comes when you start to speak on certain issues. The one example is comprehensive sexuality education, for example, and its implementation within South African schools. The young people want CSE to be provided to them. The parents are the roadblock because they don't want to have to confront the health-seeking behavior of young adults. And so as an individual, if you are not able to say, we need this service, parents, teachers, this is why you must provide, then we still have that gap. So it's capacity building as an individual, but also being mindful that you will be presented with some resistance.
Thank you so much for that, Nga. And we have just a couple of minutes before closing up, and I would just like to ask our speakers to just maybe leave us with a one-liner that you would like our attendees who joined on the Zoom platform and who are joined on our Facebook stream, just one-liner of what you would like them to take away from this webinar. Can we start with Jess?
Thanks so much. I think my one-liner is that reproductive justice is possible. Reproductive justice it depends on you and I and all of us.
Beautiful, thank you. And Gugu?
Oh, I'm still thinking. That people aren't concepts and that they're human beings, and that the revolution starts with seeing and recognizing the humanity of all.
Nga, over to you.
I think after all the richness, it's very, very difficult to just pinpoint one thing, but you have the power to change the reality that you exist in. You have the power to exercise your constitutional right, your sexual reproductive health right. It is constitutionally enshrined. Participate. If there are young people here, if there are people with young people in their communities, encourage them to participate so that we don't have to make policies and decisions that affect young people in their absence.
Thank you. And last but not least, Kelly.
I would just say that on International Women's Day, it's a day to remind all of us that sexual and reproductive health rights and justice are human rights, that each of us has a right to high quality information, products, and services so that we can have the sexual and reproductive life that we choose, and that we and our families and our communities can be happy and healthy, and that each of us can help advance that reality for every single one of us by using our resources, our individual, our organizational, our community resources to help stand with all of our civil society and organizational and professional colleagues to make sure people know that those are their rights, and to make sure that we're advancing justice as well as we can.
Thank you so much. And as we just bring this really rich and insightful webinar to a close, I just want to thank each and every one of our speakers for being part of today's session. Thank you to everyone who attended and joined in on our Zoom platform and was streaming through our Facebook live stream. It was truly a rich and enriching experience with valuable insights, and just provided us with a deeper understanding of the importance of investing in sexual and reproductive health. I hope that everyone who joined found these discussions thought-provoking and, inspiring, and just remembering that knowledge isn't gained, or the knowledge here rather, that doesn't end here. It doesn't end with this webinar. It's a stepping stone for further exploration and for further growth, and just we can carry the spirit of collaboration and learning forward through staying connected and continuing these conversations and exploring new horizons in our respective fields. Thank you once again for everyone for participating, and we look forward to welcoming you to our future events and webinars. And until then, stay inspired and keep pushing the boundaries of knowledge. Thank you, everyone.
And thanks so much to you, Sesona, and to Tanya, and to Dudu, and everyone who helped make this happen. And such a pleasure to be in space with you, and Ga, and Google, and with Jess. Thank you.
Thank you so much.
Kelly. Likewise. Thanks,
Bye,
Google.
everyone.
Thanks, Sesona.
Thanks, everyone.